Hi, everybody. I'm going to tell you a story to start with, and then I'm going to do the full disclosure. And my talk will be short, and then Jen will really get into the meat of this. So this is Tyler. He's 15. He shows up in his office. His mom's arranged an appointment for him. He missed getting his TD immunization at school. His mom forewarned you when she booked the appointment that he'd been caught with marijuana at school. She thinks he's using it on a regular basis. And so during your visit with Tyler, you start a discussion with him to ask him how things are going at home and at school and with friends. So I haven't been a teenager for well over 40 years, maybe more like 50. My own 3 young adult children often bewilder me. I don't really feel like I always understand their world and their challenges. And there's Tyler in front of me, somebody I haven't seen much since he was a child. And I'm not sure what I, as a family doctor, have to offer him. And he's not really keen to be there and not really sharing a whole bunch. So this talk is about those moments. You've all been there. We've all been there. What I know about Tyler is that he lives with his mom and his sister. His dad left when he was young. There was some relationship abuse in Tyler's early childhood. His dad's now in prison. The family's struggling financially. He's not real keen on school, and he's always kind of silent when you see him. This slide is another brain slide, different than Ram's. So in our busy family practice, we sometimes forget we're dealing with that person whose brain is under construction and whose development is ongoing. They may be doing the best they can with the resources at their disposal, but their struggles might be invisible to us. And it can be really challenging to understand the cognitive and emotional sources of troubling behaviors. And so my full disclosure is that over the course of more than 35 years in practice, I hate to admit it, I have actually made all the mistakes that you can make in working with kids, my own kids and kids in my practice. I've done things like deliver lectures, do the punitive parent admonishment role, try to scare kids with consequences, try to find a quick fix, do the I know better routine, trying to hurry, view the youth as a problem to be solved or fixed. And the thing that I think is most important is that when you're with that kid, your curiosity actually has to trump your judging. That person has much more of a story than you could possibly imagine. So screening is something Ram mentioned. One of the things about having a conversation with Tyler is that you actually need to normalize it. It's easy for us as physicians to ask a lot of questions and the kids feel like they're being administered the 3rd degree. So something like, I'd like to ask you a few questions about how you're doing. Make sure I understand how things are for you. These are questions I ask most youth or most kids. And then really hone in on what might actually be happening in Tyler's life. Anybody familiar with the ACEs study? I'm betting most of you are. So this is one of the largest investigations ever conducted to assess the association between childhood adverse experiences and later life health and well-being. And it shows that certain experiences can be major risk factors for the leading causes of illness and death and poor quality of life. And as physicians, I think it's really important for us to understand how those health and social problems can arise as a consequence of adverse childhood experiences. And I think the thing I find most fascinating about this particular slide is that yellow arrow on the left, the epigenetic mechanisms, the things that affect the histones around our DNA that change the way our DNA is manifest as we grow and develop. And so what happens is an adverse childhood experience has ripples and repercussions throughout your entire life and certainly has a lot to do with disease and disability and social problems. And I guess the other lens that I think we need to adopt when we work with kids is to actually make sure that our work with them doesn't re-traumatize them, doesn't cause them more problems. In order not to re-traumatize youth, you actually need a pretty high level awareness of their emotional state and our own emotional responses to all the aspects of caring for that person. So it doesn't mean you have to be fake or hide your feelings. I've done that one too. But kids know when we're not authentic. We do, however, have to have a fair bit of control over our responses and our own distress. And when we watch the video later tonight, you'll watch a really classic example of that. And I guess the other piece is that if we connect with other people who work with youth, we then make sure in those conversations that we have that we can then offer youth the best care available. But creating a youth-friendly environment can mean a lot of different things, but mostly it means seeing kids with positive regard and working with them where they're at. And I'm conscious that I'm not politically correct and I keep saying kids when I should be saying youth. So the best predictor of providing good care is actually the quality of your relationship. And you do have to be explicit about confidentiality up front. You can't save that conversation for down the road. Nothing that you tell me will be shared with anyone without your permission, unless I'm seriously concerned for your safety or someone else's safety, is one of those things that has to happen early in the conversation. And you don't have to know how to do CBT. Motivational interviewing is a pretty good skill to have worked on with kids. But you do need to have empathy, and you do need to be able to build some rapport. And I guess the other piece is that when somebody is activated, they're anxious, they're irritable, they're angry, if you approach them with logic, explanations, problem solving, you probably are going to escalate their activation. So our desire to be logical and rational and solve problems in the time frame that we have in our practice has to be set aside. We have to acknowledge strong emotion and address it, but don't necessarily assume you know what someone is feeling without checking with them. Emotions aren't good or bad, they just are, and they can't be satisfied by logic, but they can be supported and satisfied with empathy. And then I guess the other piece is that most youth have some innate resistance to being told what to do, particularly when you're the authority figure. And one of the worst traps that, again, I've fallen into is if you hear their story and your heart sinks, and you start to feel hopeless about what you have to offer them, actually they know that you're feeling that way. And so one of the things that's been really important for me is to learn how to cultivate optimism and to recognize that I have a moral obligation to cultivate optimism on behalf of someone who's struggling, and to support them to find their own strengths and possibilities and ability to go forward. So as family physicians, we're really uniquely positioned to see the whole picture, to offer our support to maintain that longitudinal relationship. Youth need us to listen, and listening deeply is different than listening for 30 seconds and figuring you know what's going on. The quality of the relationship we have with them will determine how supported they feel. And please don't ever underestimate your importance as their family physician in being a supportive, non-judgmental adult in their lives who can try and help them find their way. I'm going to hand over to Jen, that's kind of the meta stuff. She's going to get into the less meta stuff.
Okay, thanks Ellen. Okay, so we're going to talk next about youth-friendly environment. And this is something that working at the youth clinic, I have to say, I feel so lucky to work there because it is so youth-friendly. So we've created a clinic there where we have a drop-in from 11 to 5. We accept everybody. We don't say no to anybody. We have some appointments, but if you miss that appointment, we're not going to get mad at you, or we're not going to charge you any money, right? The moment you walk into the clinic, there's usually someone smiling at you. Sometimes we have a volunteer offering cheese and crackers. And we have just a friendly staff that is really warm and welcoming, okay? Now, I have also worked in a fee-for-service practice, like most of you, and I understand that it's not everyone can set up a youth clinic, right, in their practice. But one of the things I do know, working with youth, is that we do have to make a little bit more effort in making our spaces youth-friendly. And one of the things I think about first is really thinking about appointments and how we are helping youth access our family practice offices. Now, youth, as you know, they are independent. Many of them are independent, and they want to do their own thing, and they want to make their appointments once in a while. So sometimes, yeah, if they're going to make an appointment with you in your office, you're going to have to educate your staff about youth accessing your clinic. It might mean that you might have to be more flexible. Sometimes, I know some doctors will leave that time 3 to 5 in the afternoon available specifically for youth. If they miss an appointment, hey, it's okay, give them a little break a little bit, right? We also talked about, Ellen was talking about the challenges in the brain, okay? So it's going to be challenging for a youth to keep an appointment. And how we talk to a youth. At the youth clinic, as you know, a lot of youth nowadays aren't talking on the phone. So we're doing a little creativity as we're doing some texting, some phone calls, we even do some Facebook messaging. But I think for the future, a lot of family doctors might have to do reminders and just think a bit more creatively how we can connect with our youth. And as Ellen suggested, we just have to talk about confidentiality too. So once we've built rapport, you have some empathy, and maybe you have a youth-friendly space. Our next thing that we're going to talk about is SBIRT. So has anyone heard of SBIRT? I know Ron was talking about it earlier. So just to warn you, before I go on in this evening, the doctors love mnemonics, okay? We had to memorize so much stuff during med school, so I think there's a word for everything. So SBIRT is a mnemonic, okay? But if you Google it, it's out there, it's true, it's a real thing. And it is an evidence-based approach, and it really talks about identifying, reducing, and supporting substance use and mental health issues, okay? So what it represents. So S is for screening, the B and the I is for brief intervention, and the R and the T is for referral for treatment. So the first part is screening. So many of you, as a family doctor, might have screening tools in your office. You have the GADs and the PHQs. Those are quite easy. You can give in the waiting room. You can have them on your EMR. Screening for substance use. A lot of people use the CAGE questionnaires for the adults. Do you guys remember the CAGE? So it stands for C is, do you want to cut down? A is being annoyed. G is do you feel guilty? And E is eye opener. It's kind of familiar to you guys. But in the youth population, in the young population, the CAGE questionnaire actually hasn't been shown to be developmentally significant. So we use the CRAFT. And the CRAFT screening tool, I don't know if any of you guys have heard of that. So C, you're going to think of car, okay? So you're going to ask them, hey, have you ever been in a car when the driver's been high, or have you yourself been high when driving? R stands for relax. Do you use substances to relax? A, alone. Do you use substances when you're alone? F is for friends or family. Do your friends or family ever tell you to cut down? Okay. F can also be for forget. And this is quite common, So when you had alcohol last weekend, did you forget what happened? And T is trouble. I ask that a lot. Does using substances ever get you in trouble? If you score 2 or higher, it puts you at a higher risk for a substance use disorder. So another great approach is the heads. Now our youth clinic team, we've been teaching medical students for probably 10 years now. And we actually get really excited about it because we talk about the heads. And it seems like a real basic thing, but we use it all the time, every day. And I encourage you guys to adopt this approach. It's a psychosocial way of interviewing youth. And what's great about it, and you can see it all, again, stands for things, is that you can start with some really easy questions to ask youth, right? You can ask about the home, you can ask about what they like to do for fun, you can talk about school, and then you can dive into the more serious stuff, which is the drugs, the sexuality, the suicidal thoughts, things like that. And some of the pearls, and you might want to write these down because I tell these to the medical students every day, because these are hard questions, right? And they're awkward, they're sometimes uncomfortable questions. And so when you get to the D, the drugs and the sexuality stuff, some things you might want to say, and I think Rami mentioned this too, is you can mention, so do your friends use drugs? Do your friends drink alcohol at parties? And then you can go in, do you? Or sometimes we say, some people use substances, or some people smoke meth. Do you? That kind of stuff. So you can kind of, go around it that way. The other pearl I like to ask, or how I like to ask questions, is you can say, hey, tell me what it's like for you at home. Tell me what it's like for you at school. Tell me what it's like. You know, that tell me, I use it all the time because it really just allows them to tell you their story. So when you're talking about substances and drug use, you're really going to focus on the type of drug, the amount, the frequency, but most importantly, you're going to focus on harm reduction. So you guys all know now, if someone comes in your office and you find out they're smoking pot, if you say, don't do that, stop smoking pot, is that going to work? The abstinence model doesn't work, right? So for young people, the topic of education shouldn't really be on stop doing that. It really should be how are you going to use safely? And that's really what about harm reduction is. So if someone comes to your office this week and you find out they've been drinking alcohol at the party, you might want to ask, oh, okay, so who else is at the party with you? And if you're drinking, how are you going to get home safely? Or how are you going to control the amount that you drink that night? Stuff like that. Or if one of your patients you find out is injecting drugs, you might want to ask, where are you getting your needles? Are they clean? Are you sharing them? Where do you pick up your supplies? And then you might want to take a next step further and say, have you had any blood check for HIV or Hep C? So that's all part of harm reduction. So we're still talking about SBIRT, right? And we're into the brief intervention. So harm reduction, the heads. Another big thing is motivational interviewing. So I think you guys are probably all experts in this, right? Being family doctors, and some of you have probably done workshops in it. And if you haven't, you should sign up because it's really, really fun. Some of the things with youth that we work on is expressing empathy. So youth, they're going to be really amazed if they know that you care about them. And so the saying we have, walk in my shoes, try and really imagine what it might be like for that youth going through their struggles and experiencing their past, because that really helps you feel and care for them. Supporting self-efficacy, okay? Youth have a really big belief to succeed in life, okay? That's why I love working with youth, because they have great ideas. Often they're very, very positive. They dream big. And so don't squash it, right? Listen to that, follow it, and believe it. The bottom one, developing discrepancy. A lot of times young people have some amazing goals, but what I find motivates them is if there's a big gap between where they want to go and where they are today, sometimes that motivates them to maybe make some changes in their life, okay? The role with resistance, okay? We all know here, it's hard to change. It's really hard to make a change, right? So there's this law of, what's it called? Sauter's behavior law of change. You guys heard of that one? So what is it? People will change when the pain to change is less than the pain to stay the same. So that means that we're all going to take the easy way out, right? So when it gets so bad, then you might change, okay? So that's just the thing that people do, I think. So recognizing that people are going to fight you. They're not going to want to change. So we're going back to Tyler now. He's now 17. Tyler comes to your office. He's now very, very sad. He's depressed mood, he's crying every day. He's preoccupied that his girlfriend has broken up with him because of his substance use. He admits to you that he's smoking pot every day and he's drinking heavily on the weekends. So much so that he's now getting into fights. He's starting to get into trouble. And not only that, his mom has threatened to kick him out of the house. So this is true. This is a typical patient actually. We see this a lot at the youth clinic, but you're going to see this week. You might see this, right? What are you going to do? So it's a little bit overwhelming, right, sometimes? Because you're thinking, wow, Tyler's got a lot of different issues going on right now. And I can understand for a lot of doctors, they might want to, excuse me, I'm just going to leave the room and try and phone somebody or something like that, or phone a psychiatrist or maybe an outreach or something like that. And I get that, and I feel like that a lot actually. But before you do that, you might want to think about these questions. Because right now, we call these the getting unstuck questions, and we're going to go over this in your group. So, because right now, when I think about Tyler and all the things that are going on in his life, I really kind of want to know what is the big thing that's bothering Tyler right now. So I'm going to ask him that. I'm going to say, what is it that troubles you the most about your situation? Okay, that's going to be really important because right now in my head, I'm thinking, there's so many things going on here. I'm a little overwhelmed. So just ask him. What is it that's troubling you the most right now? And then find out the feeling that's involved. How do you feel about this? And then, what do you think you could do about it? So those are 3 questions that we're going to actually work on later. So this is Tyler's response, okay? Tyler is very worried that he's going to end up in jail like his dad. He's also worried that his mom might kick him out of the house. He's worried about what his friends might think of him if he's crying, okay? He's worried that he can't stop using drugs. And he's also worried that he might kill somebody because he's so mad. When you ask him about his feelings are one of anger, hopelessness, right? He's really pissed off. I hate everyone. I wish I wasn't here. Okay? So the other question, remember we asked is, what do you think you could do about it? This will lead into a care plan, which is the next real important thing that you're going to be doing with your youth when you see them in the practice. And a care plan, when I think about a care plan, because I know as a fee-for-service physician, when I think of care plan, I think chronic care billing and all that kind of stuff. You think of all these details, and that's not what we're thinking of. We're thinking of a care plan with the youth, for the youth. So this isn't going to specialists, this isn't anything to do with billing, this is something for the youth. So remember that foggy brain that, it has to be simple. It's has to be very, very simple language. Okay, and you're going to create it together with the youth, one step at a time. So to make a care plan, what we like to focus on is let's first start with what's working. Okay, what are your strengths? And that's really, really important right now, because I'm thinking about Tyler, and at this point, I don't really, in my head, what he's told me, nothing's really going well right now, but I'm going to find really hard what is working in your life. Find that out, because that's going to be really, really important. Safety plan. Say, what if you're not better? What if you're getting worse? And this question is really important, especially when we talk about suicidal risks, that kind of stuff. So if you're not getting better, you're not getting, or you're getting worse, what's the plan there? Who can we share this plan with, okay? Find out if there's someone like a support person, support worker, counselor, could be a parent, could be a teacher, someone that you can share this plan with so someone else is involved. And then you talk about, when can I see you again? What not to put in a care plan? Don't put DSM-5 diagnosis or medical language, jargon. Don't put information that the youth doesn't understand. And don't put any community resources that they can't connect with. So this is Tyler's plan after you talking to him. He actually loves basketball, you found out. And he wants to still play basketball on Friday nights, and he agrees to do that and be sober. He also wants to talk to his mom and talk about the expectations for him to stay at home and what he needs to do. And if things get worse, he agrees to call his friend. And I would probably add in there maybe a crisis number to call if he has risks or thoughts of suicide. And he also agrees to see you in 1 week's time. So what's the likelihood of Tyler following through with this plan? I don't know, could be low. It's a lot to ask actually when you think about Tyler, but I'm gonna feel hopeful that he's gonna follow it up. But I saw Tyler, let's say, I see him in a week's time. He came in to see me, which is great. But let's say, he never got to basketball, okay? That's okay, I'm going to expect that some of this plan he may not be able to follow exactly, but that's okay. He came to see me. Maybe he talked to his mom, okay? The next step we would do is just really acknowledging that it's going to be difficult for Tyler to follow in detail these care plans. But what's going to be more important is that he knows that you're there for him and that you're going to be available no matter what, if he follows the plan or not. So when he comes back and sees you in 1 week, you're going to just reassure that you're there for him and you want to work with him. The next follow-up visit would be spent more on diving into his mental health issues, his diagnosis of depression, and his substance use. And then you would probably take a next step further and really connect him with the community resources. But by this point now, I'm confident that I've built a really good relationship with Tyler and that he'll be coming in to see us for follow-up. Okay, so this is our last slide. So in summary, okay, I just want to let you guys know that you guys will see a youth in your practice that will present with mental health and substance use issues, okay? So when that happens, show care, show concern, show kindness. Know that empathy is the first thing to show when you're trying to build a trusting relationship, okay? We as family doctors have a big impact on connecting youth with effective treatment and community resources. Thank you.